Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon. Today, after a long break, I think I want to share with all of you about one of the common disease related to upper GI. Common you see patient presented with upper gastric discomfort, and then the results of endoscopy come back as mentioned, either reflux, esophagitis, or sometimes not very rare, but you can get the findings such as Barrets esophagus. So what actually Barrets esophagus is? Okay, before that, what is esophagitis? Okay, all patients come with upper GI symptom, vomiting, burning chest, upper chest pain, or epigastric pain. If patient is fit, this patient will undergo endoscopic examinations. Okay, and we want to rule out the commonest cause like peptic ulcer disease. They can have the symptoms as erosions, ulcer, and they can be other causes also. And last but not least is cancer. Okay, we cut off other diagnoses. We want to concentrate on esophagitis. Okay, when we call it esophagitis, so when you did scope, and after excluding all the gastric and duodenum problem, and you can see some form of erosions in the lower esophagus. In the lower esophagus, there is one line, what we call a Z line. Z line is the line of differentiation between the margin of the esophagus and stomach because of squamous columnar lining. And roughly the distance of the scope between upper incisor and the cardiac-esophageal junction is 40 centimeter. So you see that usually it is white line like this, and then between the esophageal and stomach mucosa, you can see smooth lining, smooth mucosa lining without ulcer or erosion. If there is erosions, usually we grade it into 4, either by LA classifications or Severy Miller classification. You can read now, I don't want, but I can just give roughly about the grading. For example, the popular Severy Miller by presence of ulcer, whether it is single column, double column, grade 1, grade 2, or whether it is circumferential, grade 3, and whether there is evidence of complication like stricture or ulcer. LA is more definitive, more detailed. For example, grade 1 is single erosion, linear, which is less than 5 millimeter. Grade 1. Grade 2 is more than 1. Alright, more than 5 millimeter, but does not confluent much between top of two mucosa lining. Whereas grade 3 is involve the circumferential, and ulcer tu banyak, more than 75%, but not all. Whereas LA4 means full circumferential, full circumferential. Okay, that is tak ada masalah. That is what you call as reflux esophagitis. Lepas tu apa lagi patologi in the esophagus? You can have deep ulcer. Deep esophagitis means the erosions, ulcer has go deeper and involve submuscular propria. So these are deep seated ulcer, and this presentation usually lebih more vomiting, more epigastric pain, and occasionally they can have what we call can progress into esophageal web and esophageal stricture. esophageal web or esophageal stricture. So if there is esophageal stricture, it is basically this stricture is at the level of arch of aorta, at the level of arch of aorta, and this is called Schatzki's ring. Okay, Schatzki's ring, Schatzki's ring, and this Schatzki's ring is as a result of deep ulcer and continuous fibrosis of the previous ulcer. And last, yang we need to be very careful when someone said there is evidence of island of pink mucosa in the esophageal side, above the Z line, island of pink mucosa, which is irregular. This island of pink mucosa usually is intestinal metaplasia of the columnar epithelium. Sometimes you can have columnar epithelium of gastric in the lower part of esophagus. That is not considered dangerous, but we are worried if it is columnar epithelium ni come from the intestine. So to differentiate, you have to take the biopsy. So biopsy, we say this is columnar epithelium with the presence of goblet cells. If goblet cell ada, means it is intestinal metaplasia. Intestinal metaplasia is actually dangerous because it actually change the surrounding and can undergo dysplastic changes later. If you change the environment and the acidic, because goblet cell, they are the mucin containing acid. So after some time, it can causing dysplasia. So management macam mana? Okay, dapat kes macam ni for esophagitis or what, usually is lifestyle changes. So patient ni need to reduce weight. Common is smokers, and white people, Western. Usually we need to ask them to reduce weight, reduce stress, go for exercise, and then avoid late night dinner. We advise them to take dinner before 7 o'clock and take small meal rather than big bolus of meal. And special advice, when they lie down on bed, they have to prop up the upper part. They have to prop up the part. This is medical management. And plus, patient should be on PPI. Alright, PPI BD dose. PPI BD dose for like 3 to 6 months. And we repeat the biopsy. So if it is biopsy done every year for the intestinal metaplasia without dysplasia. So we do every year for 3 years before we discharge the patient. And then for the intestinal metaplasia with indefinite dysplastic changes, you have to treat with PPI one course. One course means 6 months. And repeat the biopsy. You repeat the biopsy every 6 months for 1 year, then every year until no more dysplasia seen. So for low grade dysplasia, we have to consider about repeating more frequent, and maybe there is a role of surgery. But if for high grade dysplasia, we need to refer to for esophagectomy, for esophagectomy or transposition of the small bowel jejunum to bypass this esophagus to the stomach. So you mobilize part of the small bowel with their omentum, and then we bypass the esophagus and stomach. Okay, that is about Barrets esophagus. So if fail for medical treatment, surgery for the reflux esophagitis, usually we do fundoplication. Fundoplication means usually most of the hiatus hernia, reflux esophagitis associated with hiatus hernia. Usually we scope, we can see there is a gap, in the scope within the size of the cardiac esophageal junction. There is a gap there, and usually the length of the esophagus shorten, like 3 centimeter, like 35 centimeter. Okay. And the other thing is, this fundoplication means if you do open, now people do most of the cases laparoscopically. They will just close, mobilize the lower esophagus, and then they will close the space behind the esophagus, the crura, they will close, and then they will wrap the esophagus 360 with the fundus. Okay, with the fundus. Alright, means they have to suture the stomach, suture the esophagus, suture the stomach back, like burying feature suture, so that there is a good sphincter down there. Okay, that is a little bit about the management of Barrets, management of reflux esophagitis. Okay, other than that, we as a general surgeon, surgical fraternity, we can diagnose, we can treat, and we must know when to refer. We must know when to refer. Which patient can continue with medical therapy, which patient should be referred for surgery. And Barrets, as long as it not undergo these plastic changes, you can still treat the patient with PPI, and repeat scope every 6 months. If there is no dysplasia, every year. If there is dysplasia, every 6 months, and see the biopsy results. If there is dysplasia, if it is low grade, different mode of surgery. If it is high grade, we need to resect to prevent esophageal cancer. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.